of pump ASD closure with a two-layer patch attached to the right atrium. This technique is indicated for repair any type of secondary atrioseptal defect, especially the ASDs, which are not often considered amenable to transcatheter closure and referred for surgery. For example, large ASDs and defect with deficient rhymes. This technique is less invasive, and it can be an accepted alternative to the traditional surgical repair for ASD. The closure of ASD is made without cardiopulmonary bypass. This procedure is performed after intravenous heparin administration. The closure of ASD is performed with echocardiographic guidance to confirm ASD closure and detect any residual shunt. A batch of pericardium from preserved calf or bovine pericardium can be used. It is then fashioned to close the ASD. The batch consists of two layers, an inferior layer and a superior layer, connected to each other so that they form a three-dimensional structure, similar to an open-mouthed pocket. The shape of each layer represents a half circle or a half oval. The opening of this structure is sutured to the wall of the right atrium. The batch size is based on the measurement of the distance between 2 and 1 and on the measurement of the ASD diameters. The orifice of the batch is sutured to the right atrium at the mid portion of the interatrial groove between 2 and 1. The superior border of the inferior layer of the batch is sutured to the mid portion of the interatrial groove between 2 and 1. The first suture is placed a few millimeters cephalad from the junction of the IVC and the right atrium. The line of the suture is finished a few millimeters of the junction of the SVC and the right atrium. The superior border of the superior layer of the batch is sutured to the right atrium wall superiorly of 1 cm for the first line of suture. The superior border of the superior layer of the batch is sutured to the right atrium wall superiorly of 1 cm of the first line of suture. A scimitar's blade is inserted through a purse string in the cavity of the batch through the upper pole of the batch. Additional measures to evacuate the air include placement of needle via the upper pole of the batch to inject the serum in the cavity of the batch to expel the air. Then the right atrium is opened superiorly 3 to 4 mm to the inferior line of the suture, and the incision is extended from blast marking suture 2 to 1. Air is expelled via the upper part of the batch. The purse string is used to secure the knife, then the stitch is tied. The batch is inverted and advanced by finger towards the right atrial cavity through the atriotomy. Thus inferior layer of the batch is positioned over the ASD. We continuously press on the inferior layer against the septum to eliminate the space between the inferior layer of the batch and the atrial septum and to detect the anatomy of the ASD so that this layer remains in direct contact with the atrial septum. Then the suture can be performed so that the suture penetrates both the batch material and the tissue at the rim of the ASD. The lower part of the batch is sutured to the lower corner of the ASD, and then the batch is sutured around the ASD with 6 to 0 per line. So the atriotomy is closed. A transparent inferior layer of the batch can be used. Then pressure can be applied on it to remove the space and blood existing between it and the atrial septum. Thus, the atrial septum and the anatomy of the ASD become visible. Then the suture can be performed under direct vision.